Usually when we talk about a medical diagnosis, there's this expectation of precision.
Right, like a math problem or something.
Exactly. It feels like engineering. Like you break your arm, the x-ray shows a jagged white line, and the doctor just points at it and says, there it is.
Yeah, you fix the part or you replace the part.
Right. But what happens when the part you need to replace isn't a bone, but a profoundly complex chemical processing plant inside your own body? Like, what does it actually mean to mechanically replace a human organ?
It's a monumental task.
Yeah.
And honestly, it is one we are still trying to perfect, even decades into doing it.
Which is exactly why we are taking you on this deep dive today. We've pulled together this massive stack of sources, so everything from modern nursing protocols and nephrology history to some incredibly intense medical ethics case studies.
There's some really heavy stuff in there.
Oh, absolutely. And our mission today is to understand exactly how we artificially replicate kidney function, the split between hemodialysis and peritoneal dialysis, and really the frontline nursing care that literally keeps these patients alive.
Yeah, the nurses are doing incredible work.
But before we get into the plumbing of it all, we need to debunk a massive misconception. Because when you hear dialysis, the first thing you tend to think is that it's just an artificial kidney that cleans the blood and boom, cures kidney failure.
Right, and nephrologists are very careful to push back on that exact framing because a native biological kidney does far more than just, filter out the garbage.
It's doing other things simultaneously.
Exactly. It acts as a whole endocrine organ. It produces erythropoietin, which is the hormone that tells your bone marrow to make red blood cells. It activates vitamin D for your bone health. It finely tunes your acid-base balances and your electrolytes minute to minute.
Wow.
And dialysis doesn't do any of that hormonal work.
So it is purely replacing the filtration and the fluid removal.
Only the filtration and fluid removal. And it does so intermittently, like in bursts, rather than continuously. This is why a patient on dialysis still needs a ton of medications for anemia and bone disease.
Because the machine isn't doing the hormone part?
Right. In modern nephrology, they measure how much kidney function has been replaced using this quantitative target called KTV.
Okay, let's unpack this. KTV. What do those letters actually represent when we are talking about a patient sitting in a clinic?
Well, it's a mathematical formula for clearance. So the K stands for the dialyzer's clearance rate. Basically how fast the machine can process the blood.
Got it. And the T?
The T is time, meaning how long the session lasts. And the V is the volume of water distributed throughout the patient's body, which is what actually holds the toxins.
Oh, I see. So it's personalized to the patient's size.
Exactly. The goal is to ensure enough blood is cleared relative to their specific volume, and a common target for a single hemodialysis session is about 1.2.
Okay, 1.2. And if a patient hits that target perfectly, how much of their normal native kidney function have we actually replaced?
Roughly 10 to 15%.
Wait, really? Only 10 to 15%?
Yeah, that's it.
Man, if 15% is the gold standard of what our modern machines can do, how did humans ever figure out how to replicate even that much of a biological organ?
The underlying chemistry actually goes way back to the 1850s. There was a Scottish chemist named Thomas Graham, and he described dialysis as this separation technique.
Okay, 1850s. But putting that into a person is a whole different ballgame.
Oh, completely. Applying that theoretical chemistry to a living human body took decades. The first attempt at hemodialysis on a human was in 1924 by a German physician named Georg Haas.
What kind of equipment was he even using in 1924? Like, they didn't have synthetic plastics or advanced medical tubing back then?
No, they didn't. He had to improvise with what was biologically available, so he used animal membranes for the tubing. And to keep the patient's blood from clotting outside the body, he used hirudin.
Hirudin? Wait, isn't that...
It is an anticoagulant derived directly from leeches.
Oh, wow. He pumped leech extract into a human's bloodstream to keep a machine running.
It was literally the best anticoagulant available to him at the time.
That is wild.
But unfortunately, Haas only dialyzed patients for very brief periods, and none of them survived long-term. The technique was largely abandoned because it just seemed impossible to execute safely.
So it just stalls out.
Right, until World War II. In the Nazi-occupied Netherlands, there was a Dutch physician named Willem Kalf, and he was just agonizing over these young patients dying of acute kidney failure.
Right.
He believed if he could just clear the toxins from their blood temporarily,
Right.
their native kidneys would have the time they needed to actually recover.
So he decides to build his own machine, but he is in the middle of a literal war zone.
Yeah, he built a rotating drum artificial kidney out of whatever he could scavenge. So he used sausage casing, specifically cellophane tubing, wrapped around a wooden drum, and he rested it in a bath of fluid made from orange juice cans.
Sausage casings and orange juice cans? That is incredible. And the
Mhm.
sources note that the first 15 patients he tried this on died.
Yeah, but he didn't stop. In 1945, his 16th patient, who was a woman in a uremic coma, recovered. She was the first documented patient saved by an artificial kidney.
Wow.
And Kolff actually refused to patent his designs. He wanted this life-saving technology to spread globally as fast as possible.
Which is amazing.
It really is. It allowed others, like this Swedish nephrologist Nils Elwall, to iterate on the design. Elwall added controlled negative pressure so they could adjust fluid removal separately from waste removal.
Okay, I am trying to visualize this process in the body. If we're using cellophane and pressure, is it essentially just a macroscopic wooden Brita filter? Like you just push the blood through a sieve and the bad stuff gets caught?
Not exactly. The Brita filter analogy actually falls a bit short of the physics involved.
Oh, really?
Yeah, a water filter is just a physical sieve. You push water through tiny holes and the big particles get stuck. But dialysis relies on two specific physical principles working across a semi-permeable membrane. The first is diffusion.
Which means the waste doesn't just get trapped, right? It moves on its own.
Exactly. Molecules of waste, like urea and potassium, naturally seek equilibrium. So they move from an area of high concentration, which is the dirty blood, to an area of low concentration, the clean dialysate fluid on the other side of the cellophane.
Okay, making sense.
And then the second principle is ultrafiltration. This is where you use a pressure gradient, or osmosis, to actively pull excess water out of the blood. What's fascinating here is that Kolff solved the chemistry of pulling waste and water out, but his therapy still had a massive fatal flaw.
Which was what?
It could only cure acute kidney failure, someone who just needed to be hooked up once or twice.
Because they couldn't keep hooking them up over and over again.
Right. In the 1940s and 50s, accessing a vein or artery meant surgically cutting into it. If you do that a few times, the vessels scar shut or they clot.
And once you run out of viable veins, the treatment ends.
Exactly. Chronic, lifelong dialysis was medically impossible because you simply couldn't keep connecting the patient to the machine week after week.
So we have this functioning machine that can save a life, but a permanent bottleneck in how to actually connect it to the human body.
Yep. And that bottleneck was solved in 1960 by Belding Scribner, a physician in Seattle. He developed a Scribner shunt.
The Scribner shunt, what was that?
It was a small U-shaped Teflon tube that connected an artery and a vein outside the skin, and it was just left in place between treatments.
Oh, so they didn't have to keep cutting.
Exactly. That little Teflon tube allowed repeated, painless access to the bloodstream. It made chronic hemodialysis a reality.
And that unlocks the mechanics of modern hemodialysis, or HD. Which, crazy.
Wait.
Today, blood is pumped out of the body at a rate of, 300 to 500 milliliters per minute?
Yeah, that's right.
And it goes into a dialyzer, which is this canister packed with thousands of microscopic, hollow synthetic fibers.
And the most crucial detail of that modern dialyzer is something called countercurrent flow.
Countercurrent flow.
Right. The blood flows inside the fibers in one direction, while the dialysate fluid flows around the outside of the fibers in the totally opposite direction.
Hang on. If the blood and the clean fluid are flowing in opposite directions, why is that better? Like, I'm not seeing the physics of why that speeds up the cleaning process.
Okay, think about it like this. If the blood and the fluid flowed in the same direction, the waste concentrations would just balance out halfway down the tube.
Oh, and diffusion stops.
Exactly. Remember, diffusion relies on a gradient. Once the fluid is just as dirty as the blood, the waste stops moving. By flowing in opposite directions, the cleanest fluid is constantly meeting the cleanest blood at the very end of the line, while the dirtiest fluid meets the dirtiest blood at the beginning.
So you maintain a concentration gradient across the entire length of the dialyzer.
You got it. It maximizes efficiency.
Okay, so the mechanics are highly refined, but it still requires serious vascular access. A patient needs a surgically created AV fistula-like, a reinforced connection between an artery and a vein, or a synthetic AV graft, or a central venous catheter. And this requires the patient to sit in a clinic for 3.5 to 4 hours, 3 times a week.
It is a massive lifestyle disruption.
Yeah.
Going back to the early 1960s, the introduction of the Scribner shunt created an entirely new crisis.
Because suddenly everyone could theoretically live.
Right. Chronic treatment was possible, but the machines and the personnel were incredibly scarce.
So we have the technology to save lives, but a hospital might only have one machine and 50 patients who desperately need it.
Exactly. There was a guy named Clyde Shields, a machinist in Seattle in 1960, and he became the very first chronic hemodialysis patient. He lived over a decade on dialysis, proving this wasn't just a stopgap.
Wow, a whole decade.
But by 1962, the Seattle Artificial Kidney Center was completely overwhelmed. They had to form an anonymous committee of lay people to choose who would receive the life-saving treatment and who would be sent home to die.
Oh, man. The sources referred to this as the God Committee, which is a nickname given by Life magazine at the time. It's an agonizing piece of medical history. You have a panel of ordinary citizens like a lawyer, a minister, a housewife, a labor leader sitting in a room looking at anonymous patient files.
It remains one of the most studied cases in medical ethics regarding resource rationing because they had to weigh criteria like age, gender, marital status, number of dependents, income, net worth, and even church attendance.
That is incredibly heavy.
They were basically trying to determine social worth to allocate a scarce medical resource.
And the financial cost was also astronomical for the average person. This rationing and financial burden really reached a tipping point in 1971. A patient and activist named Shep Glazer went to Washington, D.C. He actually underwent dialysis physically on the floor of a congressional committee room with a needle in his arm. He wanted to visually demonstrate to politicians that ordinary Americans were dying simply because they couldn't afford access to this machine.
And that demonstration profoundly impacted the legislature. It directly led to the 1972 Medicare End-Stage Renal Disease Program.
Which is wild because it is the only disease-specific entitlement in U.S. healthcare history. If you have kidney failure in the United States, Medicare covers you, regardless of your age. The government basically just absorbed the cost.
Yeah, the funding was secured, which expanded access immensely. But the medical field was still figuring out how to deliver the therapy safely. They initially assumed that if someone's blood is full of lethal toxins, the goal should be to clean it as rapidly as possible. Just run the machine on the highest setting.
I mean, that seems like common sense. Get the poison out quickly.
Here's where it gets really interesting, though. It led to a severe complication we now call dialysis disequilibrium syndrome.
What happened?
Doctors didn't count for the unique physics of the blood-brain barrier. When you pull urea out of the blood extremely fast, the blood becomes clean very quickly. But the urea trapped inside the brain tissue takes much longer to cross back into the bloodstream.
So you end up with a high concentration of waste in the brain, but a low concentration in the blood.
Which creates a massive osmotic gradient. Water always follows solutes, so water literally rushes from the blood into the brain tissue to try and balance out that concentration. Yeah, this causes the brain to swell rapidly cerebral edema. Patients experience severe headaches, confusion, and in the worst cases, seizures and coma.
Wow. The cure was moving too fast for the body's compartmentalized chemistry, so how is that prevented today?
A patient's first few dialysis sessions are deliberately shortened and run at a much slower speed, just allowing the brain time to equilibrate with the blood.
That makes total sense.
They also had to learn infection control through some tragic trial and error. In the 1960s and 70s, many centers reused dialyzers and tubing across different patients just to save money.
Because sterilization protocols weren't what they are today.
Exactly. And it sparked massive hepatitis B outbreaks among patients and staff.
Which fundamentally reshaped modern CDC infection control protocols. It's the primary reason hepatitis B vaccination is absolutely mandatory and heavily tracked for dialysis patients and staff today.
Definitely. And, throughout all this development in hemodialysis, there were researchers asking a completely different question. Is there a way to do this without a blood circuit at all, like without ever removing blood from the body?
And this brings us to peritoneal dialysis, or PD.
Right. In 1968, a surgeon named Henry Tankoff developed a durable, implantable silicone catheter. Then in 1976, researchers Popovich and Moncrief described a continuous ambulatory method.
But how exactly do you filter the blood without pulling it out of a vein?
You use a filter the patient already has inside them. The peritoneal membrane.
Yeah, the abdominal lining.
Yes. It is the thin lining of your abdominal cavity, and it is richly supplied with tiny capillary blood vessels. So in PD, sterile dialysate fluid containing dextrose, which is sugar, is infused into the belly through that permanent Tankoff catheter.
And it just sits there?
Yep, it just sits there, or dwells in the abdomen. The sugar in the fluid creates an osmotic pull, drawing waste and excess water out of the surrounding capillaries and right into the fluid. After a few hours, the dirty fluid is just drained out and discarded.
And patients can do this manually about 4 times a day, or they can use a machine called a cycler that does it automatically overnight while they sleep. It completely removes the need to sit in a clinic 3 days a week.
It's a game changer.
But looking at the modern landscape, you have these two totally different systems: the blood circuit of HD and the abdominal fluid of PD. For a long time, there was a debate over which one was actually better.
Right. Yeah, there was this pervasive misconception that PD was just a lesser backup if a patient's veins couldn't handle HD. But when you look at large registries today, survival rates are comparable.
Really, they're about the same.
Basically, yeah. The difference lies in the shape of the lifestyle trade-off. PD better preserves any residual kidney function the patient still has left. Because it's continuous, it avoids the harsh fluid and chemical swings of HD. It also offers immense autonomy since it happens at home.
While HD offers intensive, heavily supervised clearance where medical professionals manage the entire process.
Exactly. The choice today really hinges on the patient's lifestyle, their other medical conditions, and their caregiver support at home. It's not a question of medical superiority.
And because dialysis essentially outsources an automatic biological function to a highly periodic human-managed process, the actual day-to-day survival of the patient falls incredibly heavily on specialized nursing care.
Oh, entirely.
Take hemodialysis nursing. A patient walks in, sits in the chair. What is the nurse looking for before they even turn the machine on?
The very first priority is the vascular access. If the fistula fails, the patient cannot get treatment. Period. So a nurse will assess an AV fistula by palpating it, feeling the skin over the vein for a vibration called a thrill.
Thrill!
Yeah, that vibration indicates turbulent, healthy blood flow. Then they use a stethoscope to listen for a bruit, which is the corresponding whooshing sound of that flow. If the thrill or the bruit is missing, the fistula may have clotted.
But how does a nurse even know if a newly surgically created fistula is robust enough to be used? Because those needles are massive.
Right, they use a clinical heuristic called the rule of sixes. For a fistula to be mature enough to withstand the thick dialysis needles, it should be about 6 weeks old, 6 millimeters in diameter, no more than 6 millimeters deep under the skin, and have a blood flow of about 600 milliliters per minute.
6 is across the board, got it. And during the actual session, the nurse is fighting the physics of the fluid removal. Like they have to monitor for intradialytic hypotension, which is a sudden, dangerous drop in blood pressure.
Because the machine is pulling fluid out of the vascular system faster than the body can refill it from the tissues.
Exactly. And between sessions, the patient is given strict fluid limits. You can't just drink a gallon of water because your body has no physical way to excrete it until you sit back down in that chair 2 days later.
Not just fluid either. It's strict potassium and sodium limits as well.
Right.
Now contrast that highly monitored clinic environment with peritoneal dialysis nursing, where the patient is managing their own care at home.
The risks there must be completely different since there is no blood circulating through a machine.
Completely different. The core priority for a PD nurse is teaching meticulous sterile technique. Because the patient is repeatedly accessing their own abdominal cavity, peritonitis, which is an infection of the peritoneum, is the absolute greatest risk. It is to PD what vascular access failure is to HD.
And the sources mention that the primary warning sign for peritonitis is something the patient has to watch for every single day when they drain the fluid.
Yes, cloudy effluent. When the dialysate is drained out of the belly, it should be clear. If it is cloudy, that indicates the presence of white blood cells, meaning an infection has started.
And that's dangerous.
Very. Untreated peritonitis can scar the peritoneal membrane so badly that it permanently destroys the patient's ability to use PD ever again.
Wait, because the PD fluid is packed with dextrose to create that osmotic pull, do patients absorb that sugar?
They do, which means nurses have to constantly monitor for hyperglycemia, especially in diabetic patients. And there's another mechanical complication that is highly emphasized in PD nursing: constipation.
Constipation seems incredibly minor compared to blood infections or brain swelling.
I know, it sounds minor until you visualize the anatomy. A full bowel can physically press against the internal silicone catheter. It kinks the tubing inside the abdomen, preventing the fluid from draining out. A simple GI issue can literally bring the entire life-saving therapy to a halt.
Wow. When you step back and look at all of these moving parts, dialysis isn't just a machine you plug into. It is a massive, collaborative lifestyle overhaul. I mean, we started with Willem Kolff spinning sausage casings and orange juice cans in a wooden drum.
Yeah, we've come a long way.
We really have. We explored Belding Scribner's simple Teflon tube that made chronic treatment possible and the ethical weight of the God Committee that followed. We broke down the opposing physical mechanisms of HD and PD and the vital, highly technical world of dialysis nursing, where thrills, brutes, and sterile techniques dictate survival week after week.
This raises an important question as we look forward. Dialysis represents our ultimate, ongoing attempt to mechanically hack human biology. But the dialysis population is aging, and it's growing, driven largely by global rates of diabetes and hypertension.
It's expanding rapidly.
Right? We have to ask ourselves, how sustainable is it to rely on a system that requires humans to manually replicate an organ's job perfectly week after week for the rest of a patient's life? Are we pushing toward a future where we must innovate beyond the machine entirely?
It brings us right back to the beginning. We've built an incredible machine to replace the part, but it's still a machine trying to do the work of a biological masterpiece. Thank you for joining us on this deep dive. Take a moment today to appreciate those two bean-shaped marvels working quietly in your lower back, keeping your chemistry perfectly balanced without you ever having to think about it. We'll catch you on the next one.